But we'll go ahead and get started. So today's topic for our brown bag discussion series is a congressional update. A lot of you have been writing in and sending us some notes, letting us know that you're trying to follow everything Congress is discussing. It's an election year, which always makes things interesting in terms of all of the proposals that are on the table. So we wanted to take this opportunity for our brown bag discussion this month and have a conversation about what all of these proposals look like, what's on the table, what's moving, where it is, and what it all means, and also the things that we're really supportive of and that we'll be asking Congress to take action on. So if we can move to the next slide. If you're joining DPAC for the first time, welcome. We're glad to have you. This is a community of people with diabetes and caregivers and others who believe deeply that there needs to be action at a government level, in Congress, in the states, on affordability and access. So those are the two things we work on. We educate, inspire, and empower the patient community to actually raise its voice, and each of you to send letters with just the click of a button to your lawmaker. We do the heavy lifting for you so that you can be involved and aware of all the things that are happening, and make sure that lawmakers at both the federal and state level are hearing directly from the patients as they're making decisions that really are impacting people's lives. And we do this through trainings like today and other opportunities. We have state forums where we come to each state specifically and we feature state lawmakers. We have Congressional Hill Days, which we'll talk about in just a moment. And again, we have the Diabetes Leadership Council also on the line with Erica joining us. They are the policy side to our advocacy shop, and they're really focused on making sure that all of the nuts and bolts of how bills are written are exactly as they should be to have the maximum positive impact for people with diabetes. And so we're really glad to have them on today as we discuss policies in particular, and then advocacy in the ways that we can join together and raise our voice and make good things happen. Next slide, please. Just a couple housekeeping notes. This meeting is being recorded. It'll be accessible through Facebook Live and also through our YouTube page. If you've got any questions throughout this conversation, please submit them to the Q&A box, and we'll get to those either with a typed answer or we can ask them aloud as well. And then we'll send out a survey after the event. If there are other topics that you're curious about or think would be helpful to cover, we'd be glad to cover those in future events, and just let us know how you think today went. So for our next slide, I will kick things over to Erica just to set the table in terms of how we've been at this for a while.
Well, we decided to go a little retro today and pulled up the graphics from one of DPAC's previous visits to the Hill. They used to be called policy training meetings back in 2019. And I know the insulin affordability issue has been with us even before that. I believe DLC hosted the first multi-stakeholder roundtable on insulin affordability in 2016. So I think, an important note as we look through what's going on in Congress now, it's okay for us, I think, to take a moment and celebrate that it's taken a lot of effort to get this far. We still have some more work to go, but really good demonstration that advocacy is, it's a long game. We don't always have quick wins, but that doesn't mean we're not making a difference.
Definitely. And it's great to revisit this and see these BC before COVID times when we were in person and rallying on the Hill. Since then, on the next slide, you'll see how we've evolved, well, how our branding and logo has evolved, but also how this event has evolved. So what we do in this current era, and we will have events in person again, but for right now, we are able to really leverage the entire community. And instead of coming in person and trying to negotiate travel schedules and work schedules and other things, we host a virtual Hill Day, which, as you can see, is coming right up later this month. And that's where we have states coalesce together and have meetings with their individual representative in Congress and also their senators in Congress. And so it's a really good way. One of these days will be assigned to your state. So the 21st, 22nd, 23rd, or 24th If you're in the state of Arkansas, your date might be the 23rd. And so you can, it's a really good way to set aside time specifically for advocacy in a way that's very doable right from your own home, and be able to spread the message about the things that need to happen for people with diabetes. And so what are those things? Let's talk about one of the major topics of our Hill Day this year. And I will pass it to Erica just to introduce us where we are now currently in terms of affordability and access to insulin and to diabetes treatment.
Absolutely. So we've got here a little trip down memory lane. Obviously, insulin has been in the news a lot. In this session, most definitely, we are seeing recognition on both sides of the aisle and in both the House and Senate that this is definitely an issue that needs to be addressed. I think the differences we're seeing is more in the how. There's some disagreements in terms of whether we do some sort of quick fixes around the edges, or whether we just knuckle down as a country and really look at overhauling how we cover and pay for prescription drugs. So initially there was insulin specific language and broad prescription drug price reforms in the Build Back Better Act. We've got not about infrastructure. That was actually a second bill. So Build Back Better was a huge bill. It was both a framework. It was a very, very, very large, like pieces of paper stacked up legislation that had some healthcare provisions and prescription drug provisions in it. Some in addition to insulin that would be very favorable for the diabetes community. But because that bill was so big, because it included so many things, it stalled in the House. It never actually made it over to the Senate. And frankly, there wasn't enough congressional support to move it through the traditional legislative process. So they tried to move it through kind of a, I guess they call it budget reconciliation, a different mechanism to get it through with 51 votes instead of the 60 that they would need. That didn't go so well. We're still hearing some rumblings that there could be a slimmed down prescription drug bill moving. We're just not sure. The big news, the very big news, and I think still cause for celebration in the diabetes community, is that the Insulin Affordable Now Act did pass through the House with bipartisan support, primarily Democrats, but a number of Republicans as well. And that included the insulin provisions from the Build Back Better Act. So notably, it would eliminate deductibles. So if you're in a high deductible plan, you wouldn't have to pay $1,000, $2,000, $4,000 before your coverage kicked in. Your insulin would be covered on day one. It also would cap insulin copays at $35 per product per month for most people who have insurance. And that's an important note that we'll circle back on in a moment. But one of the things that we think is most important to pull through and make sure that we're messaging when we talk to Congress is it is really important to include the privately insured. So folks who are in employer provided plans, in Affordable Care Act plans, and in Medicare. So that bill again has passed, but the Senate hasn't moved the legislation. Again, this may become a theme. So in order to kind of rustle up enough support in the Senate, our diabetes caucus co-chairs, so House and Senate, Democrats and Republicans, the four co-chairs of the diabetes caucus, have agreed to try and work up a bipartisan framework to try and get enough support to get this through the Senate. So the framework itself was introduced by caucus leadership. It includes those insulin provisions from the Affordable Insulin Now Act with some interesting and frankly somewhat complicated mechanisms to try and encourage manufacturers to reduce insulin list prices. We have not seen actual language for that bill, so we can't really come up with a formal support or don't support or neutral position on it. We've seen some things in the framework that we are very much encouraged by, and we have shared some areas where we think the co-chairs perhaps could add a little more clarity, and frankly, some patient protections. You know, It's always encouraging to look at novel ways to reduce insulin costs for everybody in the diabetes community. But what we don't want to do is disrupt access for people who have good insurance now. We want to raise the level of coverage that everybody else has to that higher level and not cause some people to lose the access they have. And we want to make sure that future insulins are protected. We don't want there to be a disincentive to innovate for insulins to help the people whose needs are not yet met with what we have today. So we just want to make sure, again, that whatever moves forward protects people with diabetes.
Yeah, I really appreciate this slide because it has been such a journey and there's so much about insulin in the news. Again, particularly in an election year, we know diabetes becomes a political football. And pardon us for being a bit cheeky on some of our slides, but you have to have a sense of humor when you do this work for as long as we do it, because you have to keep coming back. And so yes, Build Back Better was not about infrastructure. It had a lot of healthcare. It was a giant bill, very, very hard to parse out, but there was a lot on insulin in there that was good, that evolved into another bill that passed the House. And now you have this proposal that, again, doesn't yet have language, but that is being reviewed and considered in a way that can help move the Senate forward. So we're encouraged by that, and we're working on that. I'll let Erica take us to the next slide.
Thanks, Julie. So here we did a bit of a compare contrast. So when DLC, Diabetes Leadership Council, and DPAC, and frankly, other advocacy organizations are looking at insulin affordability language, we at least have a little bit of an informal scorecard that we use, again, to make sure that we are looking at, if we're going to build a tent, we build a tent that can get as many people with diabetes in it, to make sure that we are moving the ball forward in terms of affordable insulin. So it will come as no surprise for those of you who have joined our brown bags and advocacy forums in the past. Preventive coverage for diabetes management is one of our main pillars. It is very much the position of DLC and DPAC that diabetes management is preventive care and should be covered as such. Ideally, that means it is covered without deductible and it is covered without cost sharing. We also recognize that that is not always possible. So if we can't get it covered with no cost sharing, we want to have it covered with low and predictable cost sharing. So something that is level across the plan year and not hitting you in January or February with a bill you can't afford, instead of spreading it out over the cost, over the course of the year. And finally, there's patient choice. Again, making sure that access to insulin is access to the insulin that works for you and not just the one that your insurance company wants you to have. So, so that's a bit of our metric. Can we move to the next slide,
Erica,
Jacob?
I was going to also just point out, we've got a couple of comments from our audience on just how diabetes management is more than just insulin. I like how we see it says including insulin. Could you speak a little bit more just to the tools and supplies and other aspects of other drugs, frankly, of managing diabetes?
Yeah, absolutely. So, again, our advocacy includes all people with diabetes. So all people, all forms of diabetes. So not just type 1, but type 2, gestational. If you have diabetes or are at risk for diabetes, again, we want to make sure that that coverage tent includes you as well. So when we look at preventive coverage, for example, in the conversations that DLC has with employers, we want them to understand that diabetes isn't just insulin. It includes other prescriptions. It includes devices and supplies. It includes insulin pumps and CGM, whatever, or systems that work together. Again, there's no one size fits all. We know that diabetes management is very individual. So we want to make sure that there is some recognition of that a lot of ways that policymakers in particular try to make things more affordable is to give fewer and fewer options. That's actually part of the problem a lot of people are having today, because there are so few options, or because you have an insurance company saying, oh, you took that insulin last year, this year we're going to switch you over to that one, non-medical switching. We are looking to minimize that. And again, make sure that people with diabetes can manage their diabetes. You're the experts. So we want to make sure that, they aren't trying to do a cookie cutter. Cookie cutter coverage just doesn't work. Did I answer that question, Julie?
Yeah, that was great. We had a question specifically too on the Insulin Now Act, if it included pumps and other supplies that fall under Part D, which is a great question.
Yeah, that is a very good question. Right now, the focus in Congress is on insulin, capping the cost of insulin at $35 per product per month. Now, and I think that's an important point. You'll hear a lot of politicians saying they're going to cap insulin costs at $35. It is per product per month. So if you take 2 or 3 different insulins, that will be 2 or 3 copays. There right now, frankly, we're working in another stream to improve Medicare coverage for pumps and CGM, but that is outside the bounds of this, this legislation, and a topic for another day. There's a lot of exciting things going on in the technology space and the coverage space for pump and CGM.
Thank you so much. Yeah, we can go to the next slide. I appreciate that.
Mm-hmm. So here we have a bit of a scorecard. So looking at the Affordable Insulin Now Act, or what we know about the bipartisan framework, we are pleased and frankly thrilled that it is recognition federally that the deductibles should be eliminated for insulin. We've known since 2019, if not before that, that employers in their high deductible plan can cover insulin without deductible. Many employers have moved that way. Now we want the government in all plans, again, employer, Medicare, Affordable Care Act. Did I catch all of them? Those are the big 3.
Yes.
Medicare, employer, Affordable Care Act, that those plans will also eliminate deductible. None of the proposals in front of us right now that we are seeing will completely eliminate cost sharing. They do, however, get, the yes vote on low predictable cost sharing. Obviously, we would love the copay to be $0 or less than 35, but for whatever reason, a lot of federal and state legislation has sort of coalesced around that $35 level, which frankly would be codifying the trial or pilot project that's going on in Medicare right now, the Medicare Senior Savings Model. It would almost take that savings model and make it available to everybody, not just Medicare beneficiaries. And broad insulin product coverage. Everything we are seeing suggests there might be some trade-offs in terms of you might not have $35 insulin of a choice of insulins, but we think that there are enough protections in place now that of the currently available insulins, that there would be enough incentive, I guess, for manufacturers, pharmacy benefit managers, health plans to work together to make sure that it's just not one insulin, or nothing.
For sure. We've spread the message so often that diabetes looks different for everyone, and that there has to be enough choice so that what works for one person, and doesn't necessarily work for another, can accommodate both of them, can accommodate the full range of diabetes. It seems so to us, it seems so common sense for these kinds of things to go through. We know that when diabetes is well managed, it can prevent a host of complications. And we also know from the government and from the payers' perspective that they're saving money as well by keeping people healthy. So it seems like a win-win for everyone. But these have only recently really begun to make their way finally into policy. And we're really, really pleased to see that. And that is thanks really to the advocacy community coming forward and explaining the benefits, explaining the impacts, and really raising their voice. So thank you to those of you who have been consistently involved in this journey with us.
Absolutely. And those offices really do want to hear from people with diabetes. I think a lot of people with diabetes, you sort of take for granted that, what you need to do to manage your diabetes is just what you have to do. For someone who doesn't live with diabetes or isn't exposed to it day to day, it is a real learning curve and an eye opener to hear from someone on what it actually takes and how certain policies can make that easier or more difficult. Little off topic for the slide, but I had to slip that in
Sure.
there. So the biggest critique of copay caps is that they don't help everybody. They don't help the uninsured. But again, we have long said that there's no silver bullet. There's no one situation to help every person with diabetes because everybody's needs and circumstances are different. They are a very important piece of the access puzzle or the tapestry. So all of the different policy mechanisms or changes that we're looking to make to kind of hit the different areas where people with diabetes might need additional support. So what we see is with a $35 federal insulin copay cap in 3 of the major markets for insurance, individual, small group, and large group. For example, nearly a third of people who receive their coverage from a state-based or small employer in that small group market would benefit from a $35 copay cap. 1 in 4 on the individual market and 1 in 5 in large employer group coverage. So what we see as encouraging to try and build, again, additional congressional support for a $35 cap, even though it doesn't solve the systemic issues, the issue of rebates, which is what really is driving up insulin out-of-pocket costs for a lot of people. It doesn't solve that, but it gives people a layer of protection until Congress can fully reform the system to something that makes a little more sense. There's wonderful momentum at the state level and bipartisan support. I believe 22 states and the District of Columbia have passed some sort of copay cap. The numbers vary, but again, that's nearly half of the states have already decided to do this, and eventually Congress is going to have to listen. We've got the Medicare Senior Savings Model, which again has demonstrated to be a remarkable resource for people with diabetes and Medicare to both cap and level out their cost sharing for insulin throughout the year. And we see minimal disruption in the commercial market because frankly, most employers and most plan sponsors are already doing this. They've either waived cost sharing entirely or they've already capped it. So this really is just encouraging kind of that smaller percentage of plan sponsors who haven't, to kind of move with the program a little bit quicker than they otherwise would. So again, we see minimal disruption in the commercial market, and that's important. Again, to not disrupt coverage for people who have coverage that they like.
Definitely, that's a great point. And on the next slide, you'll see that we've referenced these state copay caps, and the challenges with those is that some state lawmakers are saying, okay, we solved this problem. And what they're finding is that there are so many people who are not impacted by state legislation that is, moving the needle for some. It's a very small population though, about 10% of people who are impacted by copay caps at the state level. And so we have been pounding the pavement for this, change at the federal level because it is able to impact so many more people. And we know that the phrase "an act of Congress" means, like something really challenging. We know to get Congress to act is it takes a lot. And so, but we know that the impact is major too. And so that's why we keep encouraging folks, especially those who are not helped by the states that we just mentioned, who have done the good work of capping copays to go ahead and to move. But it's so important to remember that this is not a solution to the entire process. And even still with these steps, and they are positive steps and they are steps that we are advocating for, they do not help everybody, and they are not solving the systemic issues that exist within our system, which is just uniquely American. And that specifically, we're talking about the uninsured and the underinsured populations that really will still not be helped by things like copay caps, right? Which imply that you have insurance, pre-deductible coverage, again, which implies that you have insurance. So these are just good notes, especially if you're on the call and this is, that you fall into that population, that there have to be other changes as well. And we talk a lot about rebates. We can see on the next slide, and also we presented in Kentucky yesterday with some really powerful testimony from patients who have been impacted by high cost of insulin, which is incredible that people come forward and share their story, because it is what moves lawmakers to act more so than anything else. They are elected by constituents, and they need to serve their constituents to stay in office. And so it really does impact them to hear the voices that they heard yesterday in Kentucky. But we presented that, the marketplace is at least moving in the right direction. And what we see here on the left is the brand insulins, which before, too many years ago, those were the only insulins available. And the cost has gone up and up and up again, given this rebate system that we have. But you also see some cheaper options coming on the right, and even some that haven't been announced yet. And that's encouraging to us that at least there is a response to make what we call a biosimilar. So that's like a generic except for a complex molecule. So an insulin generic doesn't actually exist. It's an insulin biosimilar. And we're really encouraged to see these coming to market more and more. One even that's been approved simply as interchangeable, which is an incredible designation and step forward for diabetes care. The challenge is that on a lot of people's plans with insurance, they're still getting the brand names covered on their insurance, which means when you go to the pharmacy counter and you are in that early part of the year with your high deductible health plan, you're still paying high out of pocket costs. Another thing we've explained to members of legislatures and Congress is that there are many people take more than one kind of insulin. And so, the math really adds up. And that's why there is such a rallying cry around this crisis. But again, the challenge is that these cheaper drugs that are coming to market, they need market access. They need to be able to reach people. And if the brand names are sort of hogging the space in those lower tiers where cheaper drugs belong, that's not right. That means that we're still going to see people who are not getting access to cheaper options. And so on the next slide, you're going to see one of the things that we're working on. You see that we're working nationwide with Congress to improve prescription drug coverage, and that includes for biosimilars and generics. Again, generics because there are many other medications that many people with diabetes take. If you hear Stuart, who's a board member, he'll often say he feels like he's a walking Walgreens when he wakes up in the morning and takes all the things that he needs to take. So, that is essential, and one of the things that we feel really strongly about working on with Congress. We've worked on this bill for several years, and we will continue to raise its profile. It's bipartisan. It's had a lot of support, a lot of co-sponsors. And we're really excited to be supportive of it again on this Hill Day. We also, if you see those first two bullet points, the copay cap, the waiving of the deductibles, those are things that have broad bipartisan agreement in a lot of ways and deserve to go ahead and be in this first wave of action or whatever it is that Congress is going to do. These are the kinds of solutions we need them to be thinking about. And then lastly, rebate pass-through. That's just a challenge. And if you want to learn more about rebates, because unfortunately with nomenclature, we see this a lot. It sounds positive, but it's actually negative. Or the name is so confusing that you don't even begin to understand how it impacts you as a patient. And so we oftentimes have to unpack it ourselves and understand its impact and then help to explain that so that we're all on the same page when we're talking about these things. But you see PBMs and the middlemen and insurance companies who often own PBMs, they are getting a discounted price on the drugs, not just insulin, drugs across the board that they are putting onto their formularies, those medications that are then covered for you. And what happens is when you, the patient, go to the counter, you're not getting the benefit of that rate. So I just want to put on here that there's a lot of, you see hope, dispensary of hope. There's a lot of hope for options that are available now or in the future. Civica is a conglomeration, an effort between JDRF and a nonprofit to make $35 or $30 insulin biosimilar available for Lantus, Novolog, and Humalog coming in 2024. So again, we are encouraged by these things, but there are more systemic fixes and more that Congress needs to do to really solve this problem across the board. And we will continue to advocate for those things. Erica, anything I missed?
Yeah, if we could just go back to that for a minute, just a final point. The wheels of Congress and frankly, the wheels of state legislatures can move slow. And frankly, they most often move slower than what we're seeing in the landscape. So while Congress is looking at really important pieces of legislation, it's important, I think, as a diabetes community that we remember there is a lot we can do to raise awareness of affordable insulin that doesn't take an act of Congress, because there are a lot of resources that are available now. And frankly, for a lot of people, whether you don't have insurance or even if you do have insurance, where you might actually be able to save a lot of money by buying your insulin outside of insurance. So just, just a note that we're trying to change the whole system. We wish people didn't have to hustle with coupon codes or 800 numbers or websites to try and lower your insulin costs and your other prescription drug costs, but that's the system we have right now. So, just look out for yourselves and look out for each other. And those changes at the policy level will come.
Yeah, and there's so much blame to go around, and the drug pricing system and the challenges and the profits before patients. And several of you have even shared your personal stories in the chat of the challenges that you have with your own drug pricing, and even switching to cheaper options you've still seen challenges, whether it's because of the rebate system or not having the coverage, right, that you need to have to access those drugs at a cheaper rate. And so we totally understand and are continuing to work on these things at all levels. And we're thankful that you share your stories with us and that you're sharing your stories at a national level, because that's what's continually moving the needle. And to that point, I'll be brief because I know we're already slightly over. We would love to have you sign up for a Hill Day that's coming up. It is so critical that we meet with members and their staffers. Congressional staffers are really what make Congress go round. And so a lot of times these meetings are with their health legislative assistant or legislative director, people who are informing the congressperson's agenda, and us sharing what the things that we need to see happen and how it's impacting us directly are so critical. And so if you would like to sign up, we would love to have you. We've got a training that we'll host so that everybody is fully briefed on the asks and the talking points and the things that we'll have, as well as a state meeting where you can come together with the others from your state and strategize as well. And we'll support you all the way through that. Look out for candidates on the campaign trail. We don't want Congress to use our community to score political points. And that's really true, is to kind of have your just extra awareness of the time of year that it is, and to not get discouraged by that, to keep pushing for action regardless of what we're hearing. And then our consensus statement is headed by DLC. We were a partner in that, as were 10 other diabetes organizations, where we said, hey, there's a lot that has to be done, a lot of action that Congress can take. There's, it's not that there's no hope and that our system is just too broken. There are a lot of things that can be done, and here is what they are. And here are things that we across the spectrum of this chronic disease agree on. So we'd love for you to take a look at that. Follow us on social media for more information. And thank you so much for being with us today. We appreciate your time, and we look forward to seeing you at our Hill Day if you're able. Thank you so much.
Thanks, everyone.